set the stage for this, we're going to hear from two particular experts in the field. One is, along with Anita Altman from UJA Federation, I would say the two, and we're in Brooklyn, the two godmothers of the NORC system. The folks that had a dream and continue to dream, but made it very, very real. And on a consistent basis are the chief advocates for the continuation and the growth and the expansion of the NORC system. The NORC system, which is going to become radically more important as all of us baby boomers, I'm among them, and I felt a particular closeness to Phyllis because she's the exact age of my mom. You know, those issues that she talked about are just the issues that I sort of worry about with my mom as well. She being in Florida, like every good Jewish woman from Brooklyn, and allows me to go down there every so often to say hello, but not enough. Never enough. But these two folks, and we'll be hearing from Fredda Vladeck in just a moment, these two folks really began to dream, began to implement, and most of all, help to create a system that is helping people every single day and is going to be needed that much more as we proceed with the aging of much of our population. I know that city planning has told that in Brooklyn alone, the aging population of 65 plus will double over the next 10 to 15 years. Double. That means that we're going to be ever more challenged how we're going to handle that population. And it's going to be a very different population based upon various different immigration patterns that have happened. And the folks that we thought were going to make our senior population here in Brooklyn just 15, 20 years ago is going to be very different than who and what we thought was going to happen. So we have to be prepared on multiple levels. So what we're going to hear is two overviews, two macro views, and then we're going to be having a panel both talking about what they do and responding. But we'd first like to hear from Fredda Vladeck, the project director of the Aging in Place Initiative from the United Hospital Fund.
Thanks, Bob. I feel like we're like the U.S. Postal Service. Neither sleet nor rain, hail nor snow, they didn't say anything about us, is stopping us from doing our duty and being where we need to be. Can you all hear me? Yeah. Okay. So, many of you know that I usually talk off the top of my head, but I'm not going to do that today, so bear with me. And as Bob said, I direct the Aging in Place Initiative at the United Hospital Fund, and for those of you who don't know, the fund is a research policy and philanthropic organization that works to shape positive change in the delivery of healthcare services in New York. And the important thing for, I think, this audience is that we work at the intersection of healthcare and community care systems. And both worlds are represented here today, so I'm going to try to speak to both. So bear with me. Healthcare and community care-based care operate under different rules and regulations, speak a different language, and have a very different set of resources. A little known fact, one that Anita and I learned last week in Washington. The Federal Administration on Aging's budget of $1.6 billion a year is what Medicare spends in a day. Gives you a little perspective, right? But the two systems have the same goal, to maximize the physical, functional, and social health and well-being of older adults. These are interrelated. A problem in one of these areas affects the other. They can no longer be seen as separate. A senior who is depressed may sit in a chair most of the day. Eventually she loses muscle tone, which affects her functional health. As she sits more and more, her depression deepens, her memory starts to play tricks on her, she stops taking her medication correctly, and the cascade continues. We've all been in this movie. We've seen it, and we've tried to intervene. My whole professional life, I've been chasing the dream of coordinated, integrated care for seniors across the health and social service systems. I've worked in hospitals, home care agencies, community mental health clinics, on national demonstration programs, and in the community itself through the NORC program model. And I wanted to stop, we can't say this enough. A NORC stands for Naturally Occurring Retirement Community, and what it is a multi-age housing development or neighborhood that has a large concentration of older adult residents. It's a demographic descriptor of a community that was not built for seniors. A NORC program is a public-private on-site partnership between housing or neighborhood organizations, social service and healthcare providers, and the residents as well, to support seniors aging in place. In the mid-1980s and 90s at the Penn South NORC program, we were close to achieving that dream of coordinated integrated care across the systems. Emergency room and unit social workers from Bethesda and St. Vincent's more often than not called us when they had a Penn South senior about to be discharged so that we could do timely follow-up, making sure the senior had and knew how to take her medications, had the needed services in place, and that she went to her follow-up visit with her physician. These hospitals also did what we called social admits when we had seniors who were in abusive environments and needed to be gotten to safety. The Penn South program staff called the ER or unit social worker when one of their clients was in the hospital to give information that could help in the diagnosis, treatment, or discharge of the Penn South resident, describing what the senior was like before the admission, the events, if we knew them, that led up to the admission, and what would be needed from the community when she came home. A number of doctors called us when they had patients from Penn South who needed the supports we could provide. Many doctors got to the point where they would readily take our calls from us, from our nurse or our social worker, because they understood we were picking up where they left off, complementing, reinforcing, or monitoring the care of a constantly changing patient. The visiting nurse services, CHA nurse, the Medicare reimbursed nurse, assigned to the area practically had a desk in our office so that she could hand off the home care discharge to our NORC nurse and social worker. The CASA caseworker assigned to the area was in our office regularly getting information for Medicaid certification or recertification, getting updated on the clients we had in common. Because we were on site, she expected or knew we were more up to date on what was going on and what, in addition to the personal care, it takes to maintain in such individuals at home. Jewish Home, one of the NORC program partners, in addition to providing the NORC nurse, had an on-site social worker who worked to bridge the back and forth transitions, if you will, for seniors who use the home's adult day program. This was before short-stay rehab was as big as it is today. The geropsychiatrist fellows from St. Vincent's came on site to provide consultation to staff and in-home assessments for clients with psychiatric symptoms. And the local Meals on Wheels provider, which was Fulton Senior Center, and the local ISEP provider, which was Project Pilot, because back in those days they were separate, met every 3 or 4 months with the Penn South staff for shared care planning and updating. Sounds like nirvana, right? In some ways it was. But it depended on developing organizational relationships that were mutually beneficial, being clear on what each could do and then doing it, and maintaining the personal relationships that developed over time. The world has changed a lot since then. The internet has become a way of life, virtually connecting us to one another through iPhones, iPads, Blackberries, desktops, and whatever the other terms are that I don't know. But social workers have all but disappeared from hospitals. Hospital lengths of stay have declined dramatically, and post-surgery, older adults are just as likely to be discharged to a nursing home or rehab facility than back to home. On the other hand, patient discharge information is increasingly being shared electronically between hospitals, nursing homes, and home care providers. But solo practitioners, community physicians are harder to find as health insurers and the reimbursement system places more administrative burden on them and require more accountability from them. Electronic medical records, and in some places are becoming, and in some places have already become, a reality both in hospitals and medical offices. Some even have patient portals, and so that the patients and sometimes their caregivers can communicate with providers, scheduling appointments, asking questions, finding out lab results, without actually having to speak to them. And then we have the network of aging services, which has restructured or regionalized. Meals on Wheels and ISAP contractors are not necessarily the local or known community agency, and they've restructured in order to achieve some economies of scale. So it gives you a sense of what was, what is, what's coming, and the world is still changing. The two biggest drivers of this changing world are health reform, which is, we know as the Patient Protection Affordability and Care Act, or ACA or PPACA, depending on who you are and which acronyms you like, and as well as budget deficits. And yesterday, Governor Cuomo announced the huge cuts that we're about to see. We've all heard about those in Congress who are trying to repeal health reform. And there may well be some small scaling back of the insurance part of health reform. But the systems and payment change stuff is out of the bag, and it's happening, ready or not. We're in a time of unprecedented experimentation and change, with the aim of improving quality, reducing costs, and ensuring access and an improved patient experience. Health reform has a dizzying number of provisions, many with dollars attached, that will change how healthcare is organized, delivered, and paid for. I think a number of these provisions have the potential to change the roles of many in this room, changing how we work together to achieve the three aims of quality, cost, and patient experience. The list of the provisions is dizzying. I mean, absolutely dizzying. There's the Center for Medicare and Medicaid Innovation, the Coordinated Healthcare Office, the Community-Based Care Transitions Program, the Independence at Home Program, a demonstration program, the Bundling Pilot Program, and on and on and on. Those are just a few that may have some relevance to people in this room.